I am Dr. Sadaf Imtiaz. I am the teaching coordinator here at UKRST. Thank you so much, everyone, for joining us this evening to this radiology webinar series. As you know, today is the second session of this series where our speakers will be discussing the topic of perfecting your radiology requests, the vetting formula. We will hopefully learn today how to make the most effective and accurate radiology requests to optimize patient care. This, as you all might know, is a 4-session series, and it is designed keeping in mind junior doctors and medical students to enhance their radiology skills. And each webinar covers key topics and practical tips in radiology, from interpreting chest X-rays to identifying critical findings in CT scans. Before moving on, I would like to remind all of our participants a few housekeeping rules. First is that all of the participants' microphones and webcams need to be turned off so that only the speakers and their presentations are visible. Secondly, this webinar is being recorded so that it will be made available on YouTube at the UKRST channel later on. We will share a feedback form towards the end of the session, and we would really appreciate if everyone can fill that in, because that will be used to issue you your certificates as well. I would like to quickly introduce my team members who have very kindly joined us today here. First, I have my teaching coordinator, Dr. Maggie, who is also a radiology registrar. Thank you, Maggie, for being here. Then we have two of our very creative and amazing social media managers, Dr. Numris Chek and Dr. Behram. Then we also have Dr. Dalia Idris, who is a GP trainee, but is also the digital content lead here at UKRST. And last but not least, Dr. Abira Khan is here, who is a consultant neuroradiologist at Oxford University Hospital, but also the chief organizer at UKRST. Great, so thank you everyone for joining us, and they all will be helping to moderate the session, and Maggie will also be co-hosting towards the end. Right, so now I would like to introduce my expert speakers who are here today. First is Dr. Arjun Vora, and second is Dr. Jessica. Thank you both for being here. They both are ST3 radiology registrars in the West Midland Deanery, and I'm pretty sure they bring loads of hands-on experience to guide us through this session today. And before any further ado, I would like to hand over to Dr. Jessica to take us through the session. Thank you.
Hi everyone, can you all hear me?
Yes, we can.
Hi, I'm Jess. I'm one of the ST3 in West Midlands. Thank you for attending the webinar. So I will start the first half of this talk, and I will pass over to Arjun, my colleague, to finish the second half. So the learning objectives of this webinar is to understand the key elements of vetting a scan. We'll discuss and review some common radiology scan requests. Hopefully, by the end of this webinar, you will be able to create a concise and precise radiology request for different body systems. So we'll have a general overview of the vetting process. Then we will discuss some of the most common scan requests, including CT head, CT pulmonary angiogram, and CT abdomen and pelvis with portovenous contrast. We will then touch on the basis of triple phase scan and trauma scans. So before I start, let's look at this simulation of an interaction between clinicians and radiologists. Some of you may find it funny, but you won't be surprised because this is actually quite common in our daily practice. Sometimes we do see scan requests just saying abdominal pain query cause in our request. So hopefully after this webinar, everyone will be able to produce a better clinical requests, so we'll be able to protocol the scans better. So why is vetting important? It's because there are regulations in place that to guide us to protocol scans. This is called IRMA, ionizing radiation, medical exposure radiation. The aim is to minimize unintended, excessive, or incorrect medical exposure. Therefore, we need to justify each exposure to ensure the benefits outweigh the risk, and is to optimize diagnostic dose to keep them as low as reasonably practicable for their intended use. Secondly, this is to ensure the appropriate scans are performed to answer the appropriate clinical questions. Some of you may not know, but there are different phases of scan. For example, scans can be performed as a plain scan, or we can give intravenous contrast so that there will be an arterial, portovenous, or delay phase. So you can think of it as either not having any dye, or having dye in your arteries or your veins, or after they have passed through your whole vascular system and has gone down to your kidney into the collecting system, and that will be the delay phase. Sometimes maybe a different modality may be more appropriate to answer your clinical questions. For example, if a young patient coming with right upper quadrant pain, and if the patient is stable and the bloods are fairly normal, maybe an ultrasound abdomen would be more appropriate to find out the cause of the pain. Or if a young lady coming after giving birth and with a non-specific headache, and you want to roll a central venous sinus thrombosis, maybe an MR head would be more appropriate than the CT head. So just by the discussion, maybe we can advise a better modality of scans just to minimize the radiation, or even just to give a better answer to your question. So just to go through some of the clinical information that we'd like to see on your request. So first of all, history. What are the symptoms? Is it a headache, any focal neurology, any chest pain, any shortness of breath, any hemoptysis, or within the abdomen, any abdominal pain, any change in bowel habits, any weight loss? And we do like to know the onset of symptoms. So are we talking about days or weeks? And any other relevant signs or symptoms? And in terms of clinical histories, what kind of findings that you can find, any positive or negative findings? So any focal neurology again, any change in like chest findings, any abdominal pain, any signs of peritonitis, any guarding, any PR bleed, that kind of stuff. If the patient have any relevant past medical or surgical history, if you're getting a CT scan for the abdomen, sometimes we like to know if the patient have any past surgical history, because that may increase the chance of having something more serious like bowel obstruction. If the patient have any previous history of PE for a CT-PA scan, or previous stroke for a CT head scan. Any relevant significant medications, like if the patient is on any anticoagulation like warfarin, apixaban, just because that will increase the risk of bleeding. If the patient is on any chemotherapy, because that can affect our differential diagnosis as well. Any important blood results, so such as inflammatory markers, any raised CRP or white cell, what's the EGFR, if there's any lactate, or if you have any results of recent HB, if you're wanting to roll any active bleeding. Some smaller points to note will be the contact number and name of the responsible clinician, because if there's any urgent findings on the scan, we do like to pick up our phone and call the clinician straight away. And if the patient have a low EGFR less than 30, then we would like to know if any senior clinician is happy to override the EGFR, because according to current guidelines, even if the EGFR is less than 30, we will be happy to perform the scan as long as the clinician is happy with it. So now I'm trying to go through different CT scans by different body systems. So start with heads. Most of the CT heads are done as a plain scan, because most of the intracranial pathology we can clearly see on a plain head. So one of the most common reference that we use would be the NICE guidelines. So any change in GCS, any signs of basal skull fracture, if there's any post-traumatic seizure, any focal neurology. Some of the most common reasons for requesting a CT heads are post-fall, Curie stroke, or any confusion. So for fall and trauma, we would like to know the mechanism of injury, Is it a high-speed RTC, or is it just a fall from standing height? Any focal neurology, any signs of external signs of injury, such as any obvious bruising, any hematoma, or any clear signs of open skull fracture. As for stroke requests, we do like a good description of symptoms. So is it unilateral weakness? Where is the weakness? Is it just in the hand, or is it the whole body? Because sometimes we can clearly localize the stroke as well, just by the symptoms. We do like to know the onset of symptoms. Is it within hours? And what's the patient's functional baseline? But obviously the stroke team will be more interested in that. And lastly will be confusion. So again, what's the onset? What's the duration? And most importantly, if other causes of confusion have been excluded, like any deranged blood results or any infective causes that have been excluded. So as I said, most CT head are done as a plain scan, but sometimes we do a post-contrast CT head, but that would be mainly to look for any brain mets or brain abscess. And then let's move on to the chest. Does any know what this image is? What scan this is? You can type.
Don't be shy, someone knows. Oh, there we go.
Ah, there we go.
CTPA.
Yes, that's a CTPA. That's nice. Yes, so you can tell it's a CTPA because the pulmonary artery are bright and the aortas are dark. So most of the CT chests are done, well, not most of them, a lot of them are done as a plain scan, but mainly is because we saw some abnormal findings on chest x-ray and we would like to follow them up. So for example, any non-nodules, any cavitating lesions, any bulky hilum, or any like rib destructuring, bony destructuring, then we would like to use a CT scan just to evaluate more. But one of the most common scans that we do is actually CTPA. So when you request a CTPA, we do like some relevant history. So any shortness of breath, any chest pain, any hemoptysis, any risk factor such as recent long-haul flight, recent immobility, previous DVT, cancer. And we do like to know if you have had a look of a chest x-ray and exclude any like major abnormal findings before you get a CTPA. And with CTPA, obviously, we would like to know the D-dimer and Wells score and EGFR since it's a contrast scan. And some of you may know is if there's any PE at all on this scan. Can anyone tell me?
Bonus points if you can tell us what type of PE it is. Nice.
Yeah, there's a saddle PE. It's just right across here. So apart from doing a CT chest in arterial phase, we can also do it in portovenous phase, but that will be mainly to look at pleural enhancement. So for example, look at empyema or pleural-based disease such as mesothelioma. And then moving on to abdomen and pelvis. So just to give you a brief idea how to look at the CT scan. So imagine you're looking at a patient from feet up. So on the left of the screen will be patient's right, and on the right of the screen will be patient's left, if that makes sense. So if you look at this scan, you can see nothing is enhancing. So this is a plain scan, and you can see this big organ just on the right will be your liver, and this will be your spleen. And if you go to this image, you can see this middle structure is enhanced, and this is just to the left of the vertebral body, and that will be aorta. So this is arterial phase. And then look at this image. You can see the portal vein and the IVC are bright. So this is portovenous phase. And after all the dye has gone through your vascular system and gone down to your kidneys into the collecting system, this is what you're seeing, and this is delay phase. Yeah. So with CT abdomen and pelvis, same with other scans, we do like to know the history and examination. So where is the pain? Is it localized? Is it generalized? If there's any signs of peritonitis, any guarding, what's the onset of the pain? Any other associated symptoms like changing bowel habits, vomiting, diarrhea, or any weight loss? and any relevant blood results, so CRP, white cell, and lactate, as I mentioned before. We do like to have a few reasonable differentials in your request so we can know what we are trying to exclude for you. That would be quite helpful. So I'm just going to go through a few CT abdo-pelvic scans that we commonly do. So the first one will be KUB. This is also called, it is a low dose plain scan. So mainly we are only looking for renal tract calculus because the scan is quite low in the resolution. So we just look at calculus because they are really bright on the scan. The other one would be just a standard plain scan. It's mainly reserved for patients who have contrast allergy or low EGFR because, as I said, the definition is not as great as a contrast scan. Then we have arterial phase, but that is mainly to look at the aorta or just arterial anatomy. And then the most commonly performed scan is actually in portovenous phase, and that is good for most intra-abdominal pathology. So if you're getting an abdo-pelvis, most of the time it would just be in the portovenous phase. And then I will quickly touch on some more of a special scans. So we can do a triple phase scan, which is actually in 3 phases. So plain, arterial, and portovenous. So if you look at the image on the left, there's no contrast at all, nothing is enhancing, and this is just circling a segment of bowel. And then if you look at the middle, this is arterial phase, and you can see just tiny bit of contrast just at the edge, and that would be the bowel wall. And then if you look at the last scan, this is what we call pooling of contrast. You can see that the area of contrast has enlarged. It's because the blood has just pooled into the area. So this is the pooling of contrast. And this is the sign of an active bleeding. As you can see, the sign is actually quite subtle, isn't it? It's just quite a small blob of contrast. It's just to point out that active bleeding can be quite hard to spot. So we really do have to have the patient to be bleeding actively to spot it, or else the scan wouldn't be as helpful as you would imagine. And lastly, it will be a trauma scan. So trauma scan usually we reserve for patients coming with significant trauma. So it is done as a what we call Bastian protocol, which is actually called a split bolus as well. So basically, you just inject contrast bolus. You wait for a certain period of time, around 20 seconds, and then you inject a second bolus of contrast again. This is to allow contrast to be in both your arterial and venous system, so we can image the patient just once and look for all the pathology. It's mainly just to save time, but yeah. And just a few more points to note. Try to keep the clinical information concise and precise on your clinical requests, because we do have incidents of people just copy and paste the whole clocking document into the clinical request, which you can imagine is pretty unhelpful. It's very difficult to fish out what the important information you're trying to get across. If you're unsure why the scan is indicated, always check with your senior, because I'm sure everyone will have that incidents that your consultant wants a certain scan and you don't really think it's really indicated. So double check with your consultant, why is it needed? Sometimes maybe you can change the mind of just canceling a scan. Sometimes they may give you a better information to put in your clinical request and just help you to understand more why they need the scan as well. If the patient is stable, you can always wait for the blood results, because sometimes if the blood results are normal, maybe you don't need the scan anymore, or we can consider ultrasound rather than a CT. Try and avoid using acronyms. Does anyone know what all those acronyms mean? I know they are quite fake, but we do see in real life in our real requests. You can type again. Yes, that's loss of weight. I didn't know until I saw it yet. Any other? The STS or EOTV? I guess they are quite difficult because we don't really see it day to day as well. So STS is sit to stand, and EOTV is eyes open to voice. It's a bit ridiculous, isn't it? You can just say GCS, isn't it? But yeah. And lastly, as I said, we do like to have a contact number because we do need to pick up the phone and call you if there's any urgent finding. And that's the end of the first half. Thank you for listening. Now I'll hand over to Ash to go through some questions with you all.
Perfect. Thank you, Jess. So Jess has gone through a little bit about vetting, the process, a bit about different scan requests. So I thought for the second half of this, it will be kind of fun to get you guys to put yourselves in our shoes and become radiologists for the day. Some of you might actually be ST1 radiologists already, and this will be a good chance to have a look at some real requests. So these are actually all requests that I had during a recent on-call of mine. So we can go through them together, and basically the way it will work is I've got a little Slido quiz, so you can kind of, I know people are a little bit shy sometimes about speaking up in front of everyone, so the quiz will hopefully get you all to interact. So I'll just go to the next slide here and give you guys the QR code. So either copy the QR code or you can go to Slido and put in that code.
Okay, good. I can see people are joining. 10 users.
Yeah, thank you guys. Keep joining. Great, so we've got 18 so far, so maybe just a few more. Give you a few seconds.
Alia has also given the number in the chat box, so we'll see then if someone joins later.
Perfect, 19. Or maybe just start. As I said, the code is in the chat, so if you do want to join, you can add on. Okay, so we're going to sort of take it back to medical school, or the dreaded vignettes that you see when you're in your OSCE station. So you now are the ST2 radiologist on call, busy night shift, and you read this request for mainly. And as I said, these are all requests that I actually got on my last on call. So how would you manage this situation? So first question, 25-year-old headache, rule out stroke and end organ damage. Hopefully everyone can see the questions. So give you about 20 seconds more. Okay, cool. Let's have a look at the results. Sorry if you didn't get a chance to vote. It times out after a minute. So I will put up the right answer, and that's great. So most of you got the right answer there. So just to briefly go through the options. So reject the scan, the patient is young and unlikely to be a stroke. Well, yes, that's true that stroke generally tends to affect people of an older population, but it's not unheard of. We do see strokes in young patients. So rejecting the scan on the basis of the patient's age alone is not the right answer for that. Accept the scan sounds like a fair request. I'm glad nobody picked that because, yeah, as you're all right, that's not enough clinical information for us to determine whether this scan is needed or not. In particular, I wouldn't say it was a fair request because if you're trying to rule out stroke, it doesn't usually present with symptoms of a headache, right? So when we think of patients who are having strokes, we think of patients who are fast positive, so facial droop, slurred speech, weakness, etc. So a headache wouldn't really be matching a picture of a stroke. So I wouldn't say that you'd accept the scan on that basis. Most of you went for call the team and ask for more information. So as I said, we want to get a bit more information. If we think this is a stroke, are there any symptoms of a stroke? Like Jess said, we want to know about not only the symptoms, but the time of onset of symptoms, if they are there. And gaining a bit more information could make you more or less likely to accept a scan based on the history. If there aren't symptoms of stroke and actually it's a headache history, like the person has put in query headache, then perhaps asking a few more questions about the headache. So is this like a thunderclap 10 out of 10 headache? Are we thinking it's a subarachnoid hemorrhage? Then again, it would make me more likely inclined to accept a CT head. But if it was actually like a migraine history and a different history of a headache, then perhaps a CT scan wouldn't be indicated. So definitely that third option, as most of you have said, is the right answer. So asking the clinical team for a bit more information. Fourth option, you would never really ask them to change the request just so that they can get a scan. So that would be the wrong answer. And asking the team to request an MRI, well, it would just really delay the treatment of the patient. So it wouldn't be appropriate to refer them to get an MRI. Okay, next question. So about 20 seconds left. Okay, so a bit more of a split on this question. I agree this question is probably a little bit harder than the first one. Okay, so let's go through the options. So 82-year-old male, inpatient fall this morning, unwitnessed, banged his head after falling, and they want to know if there's a bleed. So first option, accept the scan. Any elderly patient with an unwitnessed fall could have sustained a head injury, and we need to rule this out on CT. So part of this question is true. Elderly patient who's had an unwitnessed fall, yes, definitely. Abira's got a hand up.
Yeah. Arjun, I'm sorry to cut you. Can you show the answers from Slido, like for people who are listening to the webinar later on? Can you share that screen with the answers? Like, because it's not showing up.
Oh, I see what you mean.
No, it's a different computer.
Yeah,
we cannot.
I wonder if I can.
You can log in now if you want.
Bear with us one sec. I'll see if I can log into this computer and share it.
If someone is watching later, you won't have.
Yeah, of course. Yeah, because it's recorded, right?
Yeah.
See if it goes to the same. Can you bring that on here?
Yeah, I know.
Can you see that?
Are you seeing it?
Yeah, can see that.
Yeah? Okay, perfect. Sorry, I accidentally clicked there and gave the answer away as well, but we'll go through it anyway. So the first option, yes, it's true. An elderly patient who has fallen, unwitnessed fall, could have sustained a head injury, and it may be that we do need to get a CT head, but it's not true that all elderly patients who have an unwitnessed fall need a CT head, and there are quite strict criteria. So NICE have a head CT, have a head injury, CT after head injury criteria, which we follow, and it kind of tells us whether we need to do a CT on a patient who's fallen and had a head injury based on certain criteria, which I'll go through in a bit. So the first one, although part of it is true, it's not true that all patients who have had an unwitnessed fall need to rule out a bleed via CT. Rejecting the scan, as we've already said, it might be that actually this patient has fallen and there's some parts of the clinical history that we've not fully got within the request. And so rejecting the scan would be the wrong option, because as I said, it might be that they do actually need a CT head to rule out bleed. Calling the ward and asking them to do neuro observations and calling us back if there's a change. So as radiologists, we would make clinical recommendations based on imaging that we've reported, but we would never ask you guys to change your management clinically on the ward. So that would be an inappropriate thing for us to do. Calling the ward and asking if there's any obvious head injury on examination. So a few people have put this, and that is true. As part of your process of asking some more questions, that might be something that you ask them, but actually the request already said that the patient has banged his head after falling. So it kind of infers that perhaps there already is a head injury that they've seen, and that's why they've requested this scan. So that alone would not be a reason that you would just accept the scan. So the last option, call the clinical team and advise that at present it doesn't meet the NICE criteria for CT after head injury. As I said, I'm not going to bore you with all the details from the NICE criteria, but if you do get a chance, have a quick look at it. It's quite succinct. It's like 2 little paragraphs with bullet points, and it kind of gives you the outline that we use as to whether someone needs a CT head after they've had a head injury. And most of it is centered around, 1, does the patient need the scan, and 2, how quickly do they need it? So there's certain criteria which would make us do a scan within an hour, and there's certain criteria which would give us a bit more time and we would do a CT head within 8 hours. And some of those things could be things like focal neurology, drop in GCS, post-seizure vomiting, or seizure. So those kind of things are the things that we want to know about. If your patient has fallen and it's an unwitnessed fall, by itself is not an indication for a CT head, but any of those other extra things that are in those NICE criteria guidelines would obviously make us vet your scan straight away. So that's something to think about, and the crux of this kind of question is based on that. But well done to the people who put that. That's a little bit more tricky. Okay, next question. Okay, a few more seconds left on the clock. Okay, great. So yeah, the majority have gone with accept the scan. There is enough clinical information. That is the correct one in this scenario. So this is just to kind of emphasize what a good request would look like and what kind of information we need. So if we actually just go through the vignette, that will be really helpful. So witnessed tonic-clonic seizure by wife, 3 further seizures with the ambulance crew. So they're giving me a nice, short, succinct history of presenting complaint. What is the issue? What's going on? They've given me important findings of the medical history. So they've told me straight away, not known to be epileptic. So already in my head, I'm thinking, okay, well, that's strange. Why has this person had this many seizures? Important positive findings, like Jess was saying. So GCS 3 on arrival. Yes, now it has improved, but obviously, as we can tell, that is not normal. Given a history of previous ischemic stroke, and then, as we were saying, importantly, the clinician or the team have given us some good differentials as to what they think is going on. So they want to rule out intracranial bleed, space occupying lesion, or stroke. And I'd say that with especially the first 2 differentials, it would be hard to argue against that with that history. So in this situation, accepting the scan, enough clinical information is the right answer. And just to briefly go over why the other ones aren't. So calling the clinical team and asking for more information. So that was a bit of a red herring on this, because I know for some of the other ones we've said that usually is the right option, because you have to get some more information rather than rejecting a scan. We very rarely would just reject a scan for no reason. But in this situation, actually, how long the seizure lasted doesn't really make much of a difference for me as a radiologist vetting your scan. The fact that they've had a seizure, not known to be epileptic, and have low GCS or some sort of neurology, drop in GCS would alone be enough for me to say, yes, actually, this warrants a scan. So how long the seizure lasted might be important for the medical team managing this patient, but not so much for the radiologist. And saying that you're happy to do the scan if there's a further GCS drop, again, that would be inappropriate. Rejecting the scan, GCS is improving, as we've discussed, that would also be inappropriate, given that the history is quite convincing. Call the clinical team and ask them if the patient has any focal neurology. That is something that you might do on certain situations. So, for example, if someone is presenting with, if they're querying stroke and you want to know if there is any focal neurology, but for this patient who's got seizure and low GCS, it wouldn't be appropriate to ask the team if there's any focal neurology. They've given you enough information. And again, recommending MRI instead of CT is not an appropriate management. It would just delay the inevitable scan that this patient needs. So this is an example of a good request. It kind of summarizes some of the points that Jess is talking about. Okay, next question. A few more seconds. Okay, so more of a split on this question. So 56, recent COVID infection, shortness of breath, D-dimer elevated, query PE. Let's see what people have put. So rejecting the scan first and get a chest x-ray. Often we do ask for a chest x-ray before getting a CT scan query PE, so before requesting a CTPA. But rejecting the scan and asking them to just get a chest x-ray is not the best option out of the group, because it might just be a small part of what you need to do in terms of getting a chest x-ray. So it might be that actually they've already got a chest x-ray, but they've just omitted it from the history. So just rejecting the scan straight away, it's maybe not the best idea. Calling the clinical team is the right answer in this scenario. Partly because, as I explained, it might be that they've just omitted some information from the history. So it might be that they have got a chest x-ray already and that the chest x-ray was normal. Obviously, we asked for a chest x-ray because it could explain some of the reasons as to why a patient has shortness of breath or chest pain. So if the chest x-ray was normal, then that would be your answer for that. Also, you'd want to get some more information as to what the D-dimer was. So just writing D-dimer elevated could mean anything, really. It could mean the D-dimer is 4, or it could mean that the D-dimer is 4,000. So you want to check according to your local guidelines as to what your threshold is for doing a CTPA. You want to know the actual value of the D-dimer, so that's always useful to know. So in this situation, you'd probably want to call them and get some more information about the clinical history and see whether a CTPA is warranted, or whether, of course, if they've not got a chest x-ray, you might do that first. Accepting the scan, recent COVID infection makes PE more likely. Yes, that is true. Obviously, most of us have worked through the pandemic, and you know that COVID does make you more likely to clot. But just accepting the scan on the basis of the history that they've given is not a reason to do a CTPA. You do need a bit more information. We do need to make sure that a chest x-ray is done to exclude any other causes of the symptoms. The only symptoms we've been given is shortness of breath, really, and that could be related to the COVID infection. We don't know how high the D-dimer is, so we can't say just from the history alone that COVID makes PE more likely, and so we should do a CTPA. Rejecting the scan, D-dimer can be elevated post-COVID infection. Not many people have gone for that, but yeah, again, that wouldn't be an appropriate management plan. D-dimer can be elevated in lots of different scenarios, but you would need some more information as to exactly what it was before deciding. And asking for the Wells score. So Jess did sort of touch on this and say that the Wells score is important, but it makes up a small part of the overall information that you need. So it wouldn't be the only thing that we ask for. That's probably a little bit of a trick question, I guess, because it might be part of what you ask for when you call the team, but it'll be a part of everything in terms of the chest x-ray, symptoms, what the D-dimer is, what the Wells score is, and all of that information together you would package, and in your head you would try and decide whether a CTPA was needed or not. So yeah, the right answer is the second one in this. The next question. Thanks, Abira, for answering the questions in the chat. I can see her answering away there.
Okay, we can answer also at the end.
But yeah, as Abira said, we'll have some time for questions at the end. So if you do want to save it for then, that's okay too. A few more seconds on this question, guys. Okay, perfect. So majority of people have gone for accept the scan, there's enough information. Yeah, correct, exactly. So similar to the one that we saw before, they've given us some really good history here. They've given us that she's postpartum, complex C-section, reduced mobility. So already in my head, they're giving me like red flag, could be a PE, risk factors, right? They're telling me that it's sudden onset shortness of breath and new constant pleuritic chest pain. So again, they're really pushing exactly the important findings that I need to know about. New unexplained oxygen requirement, and they've told me already that they've done a chest x-ray and it's clear, and they've told me that the D-dimer is high, but they've given me the actual value to quantify it as well, query PE. So yeah, the second option is the right answer here. So rejecting the scan, D-dimer is likely to be elevated due to recent pregnancy status. Obviously not appropriate, especially given all the other symptoms as well, and given the risk factors for PE. Call the clinical team and find out if she's breastfeeding. Reject the scan as this is a contraindication to IV contrast. So actually, it's not a total contraindication to having IV contrast. The most recent up-to-date guidelines from NICE are that the amount of iodine that's found in breast milk after having IV contrast is minimal and unlikely to harm the baby. So actually, you can still have IV contrast if you're breastfeeding. Reject the scan, symptoms are likely to be related to a complex surgery. Well, obviously that's just completely not right, and great that nobody put that. Cool. I think there's one more question left. Hopefully you guys are still with us. It's about 25 seconds left. Okay, nice. Most people have gone for the same answer and gone for recommend ultrasound in the first instance. So yeah, that's the right answer. So accepting the scan request, So on the basis of, so this was a real request that was on my on-call. So all I had was diffuse abdominal pain, distension, query intra-abdominal pathology. Based on that information alone, no, we wouldn't just do a CT scan. And then, of course, when I called them and they gave me a bit more information, so they told me where the pain is centered, right upper quadrant, it's colicky and bloods are normal. The first thing we would do in this scenario where you think it's biliary colic and there's no signs of infection or sepsis would be an ultrasound to look for gallstones or to look for gallbladder pathology. Rejecting the scan request as bloods are normal. So again, not appropriate because this patient obviously still needs some workup and needs to get down to the bottom of why they've got this pain. Accepting the scan sounds like gallstones will show up on CT. So yes, it's true. Sometimes you can see radiopaque gallstones on CT, but not all gallstones are, and so sometimes you can't see them on CT. And sometimes you need to be able to have an ultrasound, which will have ultrasound findings of like posterior acoustic shadowing, or an MR, which may show up gallstones, but it's not true that all gallstones will be seen on CT. Recommend an ultrasound is obviously the right answer, and then recommend a surgical review in MRCP. So it might be that is what ends up happening, but in this first initial scenario where the patient's presented with colicky pain, right upper quadrant, an ultrasound would be the first line investigation that we would do as radiologists. So great, that's the end of the quiz. You can see the leaderboard there. People have done very well. Oh, did you do it?
No, that was when we were testing.
So she knows the answers. That's not fair.
Absolutely.
Perfect. So actually, there was one slide that I missed out on here because So I'm not expecting you guys to remember this at all. This is just kind of a bit of information. So this is like a little performer that we have here at Stoke, or it might be used in other places as well, that we get the doctors to fill out when they're requesting some of our CT heads. And it kind of just gives you a flavour of some of the things we spoke about. A lot of the things are part of that nice criteria that we're talking about CT head after head injury. So some of the information on here, is there a history of malignancy, diabetes, ventilated, etc. But the important ones further down, so hours since injury, so basic time of onset, what's the mechanism, what's the GCS, are there any factors that would make us think base of skull fracture, because that again would make us do a CT head within an hour. So blood from the ear, bruising behind the ears or eyes, so panda eyes. Is there any vomiting? Retrograde amnesia, anticoagulation, and so as Jess was saying, important medical history or medication history, specifically with anticoagulation, because that would make a bleed more likely. Post-trauma seizure, and of course, post-traumatic seizure, and of course, if there is a trauma, has the C-spine been cleared? So if not, then we would include that in the scan. So again, not expecting everyone to remember all these things, but it just gives you an indication as to what kind of things we're looking for in the history, if they are positive and relevant. And finally, so summary of points, Jess has gone through the vetting process and how it plays an important part of being a radiologist, and the fact that we have this legal framework which underpins what we do when we vet scans, and it ensures really that we're minimizing the radiation dose and giving radiation only when it's really needed. We've kind of stressed through the quiz and the discussion the importance of good clinical history in your requests, just to help the radiologist vet the scans, and that really is essential. And to be honest, we never really want to say no to a scan. That's not what it's about. It's just about making sure that we've got the right scan for the right patient, and making sure that we're trying to make your lives easier as well by getting you the answer that you need to the question that you've asked. Discussed common radiology scans, indications, and how to perfect your request. So we've looked at some not so good requests, and everyone's done really well in identifying kind of management of what you would do. So it sounds like you guys have already got really good knowledge about what kind of things you need to be putting in your requests. And then we've looked at some really good requests as well. And finally, I mean, this is probably a broad sweeping statement, but I'm biased because I'm a radiologist, but on the whole, we're a very friendly bunch. So if ever in doubt about something, you can just call us and ask. We are here to help. So if you ever have a question about vetting, the vetting process, what type of scan you should be getting, if you're not sure, should I be just requesting a normal CT abdo-pelvis, should this be a triple phase, whatever it is, you can always ask us, and we're happy to help. And finally, thank you for attending and participating, and remember that your radiologist needs you. We rely on you guys to give us the information that we need so that we can say yes to your scans and report them and give you the answer that you need. So yeah, thank you very much. And if anyone has any questions, we would be happy to take them.
Thank you, Arjun and Jess, for a really good presentation.
Yeah,
I
thank you
think-
so much. I always wish that I'd had something like this before I started my foundation training, so I didn't make a mess of all of the requests I ended up doing in the end and getting into some arguments with radiologists because I didn't know what I was requesting. I say arguments, but it was more like being told that.
Yeah, I was the same. I still remember requesting scans in A&E just because consultants like, yeah, just get the scan, and you speak to radiology and you're like, I feel really stupid because I have no idea what I'm talking about. But everyone here in this webinar will now be able to request a good scan and they'll be like, yes.
Yeah, exactly.
Questions? Maggie, is it you?
Yeah, so I can't see that there's any questions.
There's one in which was asked, I don't know, is it TOT, is it thought? I don't know, there's a mention. Like VQ is done for postpartum, I think related to that CTPA question, is it?
Yeah, so the question that someone's written is, I don't know if you can see the chat because it's TOT. I don't know what that acronym is, if it's an acronym. And then VQ is done for postpartum.
What is the TOT? You already know me and Jess are really bad at acronyms.
Maybe they just want to say thought. Yeah, thought VQ is
Thought,
yeah.
Oh, I thought that makes sense. Yeah. Thank you, Brian. So yeah, the question is, I thought a VQ scan is done for immediate postpartum.
I'm not aware of us doing a VQ for immediate postpartum. I know that obviously intrapartum, yes, we would consider VQ, but I always assumed that postpartum, it wasn't so much of an issue. I don't know if anyone else knows any different to that.
Yeah, no, we're doing CTPAs, and even like in pregnancy.
Yeah, same.
Yeah, we would do a CTPA because VQ would not give a definitive answer. I mean, for practically, I mean, for exam purposes, maybe for MSRA, there might be a question, but not in clinical practice.
Yeah, we do CTPAs here as well in pregnant women.
Great, thank you. So we've got another question from Shreya. So do we have any set guidelines to follow? They're doing a quip to see if junior doctors in our trust do appropriate requests or not. Any suggestions?
Any guidelines to follow?
can only think of nice guidelines for the head trauma.
Yeah,
No,
there's some specific ones like the NICE guidelines that I've mentioned for CT heads after head injury, but there isn't like a reference of like gold standard requests that you should use. I'm not aware of any.
But sometimes your trust may have certain guidelines for different stuff. It's like in our trust, we got this over 50 abdo pain guidelines. So like whoever is over 50, we just kind of do a CT abdomen pelvis for them, which is a bit nonsense. We're trying to reflect the guidelines, but different trusts may have different guidelines to follow. You can just check your own trust.
Yeah, but might be worth actually finding that out, see if you do have like an abdominal pathway. I used to have that in my old ED as well. It was like an over 50s abdominal pain pathway in A&E, and it was done with A&E and radiology to try and make sure that, you know, only the scans that need to be done are requested. So you could use something like that and use that in your quip to compare as to what people are requesting and if it's getting accepted or not.
Great, so thank you. So if there's any other questions, please do put them in the chat box while we've got Jess and Arjun still. Otherwise, Sadaf has uploaded the feedback form. So if you could please fill that out for us, it means that we can get our certificates back to you. And it also means that for our future sessions, we can always strive to improve because this is sort of the first time we're running a bite-sized radiology teaching sessions.
Just one more
Thank
thing
you.
for Shreya, when you're looking at these, when you're doing this audit, the other thing you can look is the conclusion, is it answering the clinical question? or if the clinical question was appropriate. And sometimes you find like incidental findings are there. So it's basically not that, but then just having a look, like sometimes I go through the clinical patient notes and I see like, okay, fine, I see this abnormality here in the brain because I report just brain scans, but nothing is mentioned in the history. Then I just write in my report that I note from the patient's notes on EPR that patient had this. So this might be like represent a old trauma or ischemia or something like that. So that's another thing to look for, just to see if the request was appropriate. Sometimes they don't mention history of cancer, which is like really important, as Jess and Arjun had said. So yeah.
Great, thanks, Abira.
Thank you.
So I think we've given it enough time on the chats for if anyone has had any questions. So I just want to say again, Jess, Arjun, thank you so much. That was incredibly helpful. Like I said, I wish I'd had this when I was starting my foundation training and starting requesting scans too. And for everybody else, our next Bitesize radiology session is October 3rd, and that will be on plain film MSK. So please come along if you have time. And otherwise, thank you all so much for attending from us at UKRST. It's always a pleasure to host these webinars. So hopefully see you at the next session. But thank you very much. Thanks, Jess. Thanks, Arjun.
Thanks, guys. Thank you, everyone.